room. On each of the tables near the doors to the hearing room, you will find green testifier sheets. If you're planning to testify today, please fill one out and hand it to Christina or one of the pages when you come up to testify. This will help us keep an accurate record of the hearing. If you are not testifying at the microphone but want to go on record as having a position on a bill being heard today, there are white sign-in sheets at each entrance where you may leave your name and other pertinent information. Also, I would note, if you are not testifying but have an online position comment to submit, the legislature's policy is that all comments for the record must be received by the committee by noon the day prior to the hearing. Any handouts submitted by testifiers will also be included as part of the record as exhibits. We would ask if you do have any handouts that you please bring 10 copies and give them to the page. We use a light system for testifying. Each testifier will have 5 minutes to testify. When you begin, the light will be green. When the light turns yellow, that means you have 1 minute left. And when the light turns red, it is time to end your testimony, and we'll ask that you wrap up your final thoughts. When you come up to testify, please begin by stating your name clearly into the microphone, and then please spell both your first and last names. The hearing on each bill will begin with the introducer's opening statement. After the opening statement, we will hear from supporters of the bill, then from those in opposition, followed by those speaking in a neutral capacity. The introducer of the bill will then be given the opportunity to make closing statements if they wish to do so. And on a side note, the reading of testimony that is not your own is not allowed unless previously approved. And as usual, we have a strict no prop policy in our committee. So with that, we'll begin today's hearing with LB 590 and welcome Senator Holdcroft.
And this is not my first bill.
Oh, darn it.
A second.
They had so many questions to grill you on. So, okay, well, for that.
Good morning, Chairman Hansen and members of the Health and Human Services Committee. For the record, my name is Senator Rick Holdcroft, RICK, HOLDCROFT. I represent Legislative District 36, which includes Western and Southern Sarpy County. I am here today to discuss LB 590. This bill will increase the personal needs allowance for qualifying individuals from $60 per month to $100 per month. The last time this allowance was increased was with the passage of LB 366 in 2015. This bill was sponsored by former Senator Patty Pansing Brooks and co-sponsored by former Senators Kathy Campbell and Colby Coash. After being amended, it increased the allowance from $50 to the current $60 per month. Basic personal needs are provided to Medicaid recipients with alternate living arrangements as required by law. These include basic personal hygiene items such as toothbrush, toothpaste, dental floss, dental adhesive and cleaner, shampoo, bath soap, deodorant, moisturizing lotion, comb, razors, incontinence supplies, sanitary napkins and related supplies, and facial and bath tissue. If a resident chooses to purchase a specific brand that is not provided by the nursing home, their personal needs allowance can be used. According to the American Council on Aging, a nursing home resident's personal needs allowance can be spent towards a variety of personal items and services not provided by the care facility. This includes clothing, shoes, vending machine snacks, specialty food, multivitamins, haircuts, toiletries, magazines, books, knitting needles and yarn, greeting cards, postage, and cell phone bills. According to data from the Bureau of Labor Statistics, since 2015, the average non-seasonally adjusted price of footwear has gone up over 5.5%. Men's trousers and shorts have gone up over 3%. Non-prescription drugs such as multivitamins have increased in price over 2% since 2015. Chairman Hansen and the members of the Health and Human Services Committee, thank you for giving your attention to LB 590. I would appreciate it if the committee would give this bill timely consideration and advance it to the full legislature for debate. I would be happy to answer any questions you might have.
Thank you, Senator Holdcroft. Are there any questions from the committee? I have one question.
Yes, sir.
So you're saying prices for items went up maybe like 5, 6, 7% since last time we raised this?
Well, per year, yes.
Okay. Oh, per year. Okay. That's just kind of curious. All right. Thank you. Okay. All right. Seeing no questions, we'll see you close.
Yes.
Okay. All right. Good deal. Well, we'll take our first testifier in support of LB 590.
morning, Chair Hansen and members of the Health and Human Services Committee. My name is Gina Ragland, Jinaragland, here testifying on behalf of ARP Nebraska in support of LB 590. As Senator Holdcroft said, Medicaid's personal needs allowance is the amount of monthly income a Medicaid-funded resident can keep of their personal income. Since room, board, and medical care are covered by Medicaid, most of one's income must go towards the cost of their care. The personal need allowance is intended to cover the resident's personal expenses, which are not covered by Medicaid. This may include, but are not limited to, hair care, vitamins, over-the-counter, clothing, magazines, snacks, cell phone services, and others. The opportunities for these residents to spend money on things to improve their quality of life have expanded tremendously, but with that comes a price tag. The current levels of the personal needs allowance is prohibitive. For example, some female residents living in nursing homes cannot afford things like having their hair done for more than once or twice in a month. Keeping in mind, this may be the only thing that brings them joy or they look forward to every week. And then they don't have any resources left over for basic things such as clothing, phones, stamps, snacks, and so forth. Haircuts are roughly $15. Weekly shampoo and settings are roughly $20, and perms are over $20. Residents often have the opportunity to purchase a small treat for themselves here and there: popcorn, ice cream, their favorite candy. For my grandma, the one thing that brought her joy was having a small glass of red wine every night before she went to bed. Just one glass, and it was small, but it was something that she'd done for most of her adult life, and it brought her joy. But it was something she had to supply on her own, amongst other things. If they want a personal cell phone or a phone in their room, that too can exhaust their entire monthly allowance. Many people also spend $20 to $25 a month to prepay their funeral expenses so their children won't be burdened. Add all that up and you'll find the $60 comes up short. This modest increase to a resident's allowance would make a world of difference to many people. Now I want to take this one step further. I think we can all agree that the pandemic created some hardships for all of us, but those in long-term care and assisted living facilities likely have been most negatively affected. Social isolation is real. Residents were merely cut off from the outside world in lockdowns, many facing months of not being able to hug, touch, or speak face-to-face with their loved one. They had conversations with them through their picture windows or through plexiglass. Electronic devices were a must. Cell phones and tablets were a must, and not only in allowing a means to communicate with the outside world and loved ones, but also to provide entertainment while enduring the downtime. How many of you played Candy Crush, crossword puzzles, solitaire, trivia? Those are all online games, and I think we all play them, but residents do that too. Online exercise programs, online books, movies, and television programs, and many other things. But these items come with a cost. Many facilities work to provide opportunities for connection with devices, but they had to be scheduled and they were not something they could access whenever they wanted or needed to readily. Even before the pandemic, social isolation and loneliness were considered serious health risks for older Americans, especially those in long-term care or assisted living facilities. These factors significantly increase a person's risk of mortality from all causes, potentially rivaling the risks of smoking, obesity, and high blood pressure. Social isolation and loneliness are also associated with higher rates of clinically significant depression, anxiety, frustration, irritability, and suicidal ideation. Isolation and loneliness are associated with a 50% increased risk of developing dementia, a 32% increased risk of stroke, and nearly a fourfold increased risk of death among heart failure patients, according to separate studies. With 43% of adults aged 60 plus in the US reporting feeling lonely, the rates of social isolation and loneliness were already at the level of a public health crisis. We believe that increasing the personal needs allowance will allow our most vulnerable the ability to better meet their personal needs, maintain a level of independence and dignity, combat isolation, and improve overall mental and physical health, which in turn saves medical costs, especially for those on Medicaid to the state. We helped my Grandma Lizzie, nothing brought me more joy than purchasing that bottle of wine and taking it to her when she needed it. She had dementia, so she didn't know who I was, but she knew who the bottle of wine was. And truly, it's the little things that do add up. Many families help where they can and when they can, but not all families have that ability. Many have covered their costs on their own, but have depleted their savings and spent down to the point where their savings is gone, and they must now rely on the state to assist in paying for their care. My grandmother, Grandma Lizzie, saved for years and paid her way. Her life was extended due to dementia and Alzheimer's for probably many more years longer than she had wanted. but maybe it was the wine. I don't know. This in return caused her to have to spend down and rely on Medicaid and family members to assist in paying for her care. Thank you to Senator Holdcroft for introducing the legislation, and thank you for the opportunity to comment, and I would be happy to try and answer any questions.
Thank you. Are there any questions from the committee? Yes, Senator Kavanaugh.
Thank you. You just so much reminded me of my own grandmother who, at the lake that she lived at, there was a mail boat that went by 4:20 every day, and she would have her glass of Chardonnay when the mail boat went by. She
It
lived
was
to be in
red
her
wine for
90s.
grandma,
Yeah.
but it was a little bit, but it was a must, and it wasn't every night. So thank you,
for
Senator, for
talking
that.
about the importance of joy.
Absolutely. Thank you.
Any other questions? I have a couple.
Okay.
Because I have to address the fiscal note, obviously, of $2.7 million and then 3.6, which I know some are federal funds, but it's still taxpayer money.
Correct.
And the fact that we've increased it $10 every time we've done it, was last time 5, 6, 8 years ago, and we're increasing it by $40, which I know inflation has gone up and is affecting things. It just seems like a lot to me, I think. And then also, do these kinds of people that this will be affecting, do they get any other kinds of personal income? Like
So,
Social Security
okay,
or-
so to answer your first question, Senator, I know the Bureau of Labor Statistics was brought up on inflation for other things, but I also want to reference $60 in 2015 is now worth $72.18 today. So we're not to the $100 mark, but we have moved up on the scale in consideration of that, but also the cost of program services and whatever else. I think you start big. I mean, I think there's room for compromise on this, and that's what happened in 2015. And certainly if we can move the dial just a little bit further, that would still be more helpful. $100 would be fabulous, but if it gets to 70, that's something to think about too. As far as other income, when they qualify for Medicaid, they're only living off of generally their Social Security income. They have to spend down to even qualify for Medicaid, first of all. And so they're not getting anything extra in their pocket, which then, it all goes to their care, and then what's left over, the $60 is all that they have left.
So Social Security all goes towards their care
Yes.
they don't get any of that in personal income?
No, because when you qualify for Medicaid, that's your spend down.
Sure,
And
okay,
then
I
Medicaid
know a
picks up the
certain percentage
remainder.
that they still would be able to use for personal.
Just the $60.
Okay.
Mhm.
I hate to sound like the calloused,
No, it's a
but,
great
I don't want to
question.
deny your grandma her glass of wine. That's what it sounds like now. I'm like, ask questions.
Well, and $60 doesn't buy a lot of wine if you buy
Yeah.
the right kind. So
Okay, well, good. All right. Thank you very much.
thank you, Senator.
All right, we'll take our next testifier in support.
Morning.
Good morning.
My name is Edison McDonald, Edison McDonald. I'm the Executive Director for the ARC of Nebraska. We want to thank the Senator for introducing this bill. We support LB 590. Personal needs allowance is the monthly sum of money that residents who receive Medicaid may retain from their personal income. Any income above the allowance is applied toward the cost of their care. This allowance is intended for residents to spend at their discretion on items such as telephone expenses, a meal out with friends, cards, to send to family, reading materials, hobbies, haircuts, salon, hairdresser activities, clothing, magazines and books, favorite brand, hygiene and toiletry products, supplements and multivitamins, vending machine snacks, birthday cards to send to family, etc. These are the most valuable dollars to our members themselves. It's the only money they really feel like they have personal control of. Come to realize that when I hang out around our members, I can't bring a Coke without being prepared to buy a Coke for others, because even that $1 or $2 for a vending machine soda means everything to them. Or it could be a tablet in order to help communicate. But frequently they don't even get those little things, because a lot of times as you're going through the complexities of budgeting out for an individual who's on Medicaid, that's kind of used as kind of money to help when things don't quite add up, and help to make sure that really they're getting everything that they need from day to day. So with that in mind, I also want to talk about a little bit different subject, Medicaid unwind. The federal pandemic is set to start ending next month, and we will start to have assessments throughout the year, going back through every individual and redetermining their care. And with that, we're going to see a huge removal of folks off of Medicaid, but we're also going to see a huge increase, we think, in shares of cost. That's how much an individual pays in out of their pocket. So one thing that I really hope that y'all will consider within the fiscal note, the department went and said that they wanted to have it start in October. I think it would be much better and helpful for all of your constituents as you start to get those calls. One of the best flexibilities that you have are those personal needs allowances. So to go and start that, sooner rather than later is going to be a lot easier as those individuals start to really work on shifting their budgets. With that, I'll just urge your support of the bill and open for any questions.
Thank you, Edison. Are there any questions from the committee? Yes, Senator Riepe.
Thank you for being here. I will try to get back away from the testimony creep, if you will, on the other subject. Back
Yeah.
to this one is,
Yep.
Is there anything that, because of some of the compromised position of these people, even with the $40, is there someone that kind of helps them that says, you're going to want your hair done, you're going to want this, you're going to want that. Just like a youngster. Don't spend your full $60 or soon to be your, if
Yeah.
you will, 80 or 100, whatever it is. Don't
Yeah.
spend it in the first week.
There's
Compromise yourself.
Yeah, they're supposed to have the flexibility, and there's a concept called dignity of risk. Like, and basically the concept is we all have the right to be stupid and, go and say, I'm going to spend all my $60 up front because each person should have, that ability for choice. But most of the time, what you describe happens is that a staffer or a family member will say, oh yeah, you don't want to spend this all at once.
I'd hate to see them spend their full $60 on sports betting.
Yeah, but they, I would say this is money that they really learn about, they think about, and they hold on to so tightly. Where even, I was talking about going and getting a soda from the soda machine, like, that's big for them.
I was on HHS at the time when we did this major improvement up to $60, and we're assured at the time that would be forever. No. It's not true.
Yeah, I wouldn't expect that.
Yeah, well, might have been some exaggeration there, but okay. Thank you for being here.
Any other questions from the committee? Seeing none, thank you.
Thank you.
Anybody else wishing to testify in support of LB 590? All right, seeing none, is there anybody who wishes to testify in opposition to LB 590? Is there anybody wishing to testify in neutral capacity? All right, seeing none, we'll welcome up Senator Holdcroft to close. Oh, and with that, when you're working your way up here, we did have some letters. We had 3 proponent letters in support.
First thing I have to do is correct what I said earlier about the percentages. It is a total percentage over the last 7 years with a 2%, 5%. And as was mentioned earlier, the $60 back then is inflation would be about $72 now. And back to LB 366, which apparently Senator Riepe had something to do with. The original request for $75 per month, and it was reduced to $60. So it was the evil HHSS back then, I guess, it reduced that to $60. Back to the point on, and just let me relate an experience I had with my mother who passed away a couple of years ago, but she was, in the end, she thought she had a good plan, and she really did. I mean, we sold her house. She had some savings, some investments, and so she went into a home, a nice assisted living facility, with about $400,000 in the bank, and we thought that was plenty. And then we found out it's $4,000 a month to stay in a typical nice assisted living facility. That was when she first went in there, and it went up about $500 every year. So she was paying like $5,500 every month. And so that eats quickly down on your savings. And when you get down to a point where you only have $4,000 left in assets, that's when you qualify for Medicaid. And then we take their Social Security, we take everything they have in income, we pay for the rest so that they can live in a Medicaid facility, not necessarily a nice place. And then we give them $60 a month to pay for their additional costs. So I think it's been 7 years since we've raised this. We may not raise it to $100 because it does have a significant impact. As you mentioned, I would also mention there are about 6,000 residents in nursing homes that qualify for this, and about 2,000 residents in assisted living. And that's why it adds up so quickly. I mean, it's a per month fee, and you have that number of folks who qualify. So I appreciate, I'll be happy to answer any further questions that you have, but I appreciate advancing the bill.
Thank you, Senator Holdcroft. Do you think you could address the amendment real quick?
I'm sorry?
Was there an amendment that you gave to us, that you handed out?
Was there an amendment? I think there was a,
It looks like a simple amendment. I just don't know if you could.
yeah, I
touch
think
on
we
it.
changed, we took out at least. Yeah, so, let's see, yeah, there's we just struck, on page 2, line 4, we struck at least. And
Okay. Is there a reason why? Is it because there were some were people getting paid more than $60 or less than $60, or is
I'll have to
it,
get
is it
back
just
to you
more
on
kind of
that.
cleanup type thing?
Yeah.
It sounds like it. I just didn't know if there's any specific purpose behind it. Okay, cool. All right. Are there any questions from the committee?
I just have one.
Yes, Senator Walls.
First of all, thank you for bringing this bill. We
Sure.
Really appreciate it. Did you have any opposition?
No.
Thanks.
Okay. Any other questions from the committee? Seeing none. Thank you very much.
Thank you.
All right, now we'll end the hearing for LB 590. And we will move on to the next one, LB 664, and we'll welcome Senator Riepe to open. Welcome.
Thank you, Chairman Hanson. And good morning, members of the Health and Human Services Committee. My name is Merv Riepe. It's MERV RIEPE, and I represent the 12th District, which consists of Southwest Omaha and the good folks of Ralston. I have introduced LB 664 on behalf of the Attorney General's Office to make 2 modifications related to the Nebraska False Medicaid Claims Act. The first modification would parallel recently enacted federal legislation authorizing the Nebraska Medicaid Fraud and Patient Abuse Unit to investigate and prosecute cases of abuse, neglect, or exploitation of Medicaid recipients who receive medical services inside and outside institutional settings. The second modification would authorize the Attorney General access to applicable records of any resident living in a Medicaid-funded facility when investigating and prosecuting cases of abuse, neglect, or exploitation, regardless of whether that resident is a Medicaid recipient. Medicaid fraud control units were authorized by Congress in the mid-1970s to investigate and prosecute the abuse, neglect, and exploitation of residents in Medicaid-funded facilities. This congressional mandate extended to all residents regardless of whether they were on Medicaid. However, contrary to federal authority, Nebraska revised statute 68-945 prohibits the Nebraska Medicaid Fraud and Patient Abuse Unit from reviewing or obtaining information concerning a non-Medicaid resident of a healthcare facility without the patient's consent or court order. Reviews of legislative history of this passage does not uncover the reason for this prohibition. LB 664 fixes this, making Nebraska law consistent with Congress's intent and aligns this statute with similar provisions found in 49 other states. Thank you for your time, your attention, and I would be happy to take questions. Please note that D. Mark Collins, Assistant Attorney General and Director of the Medicaid Fraud and Patient Abuse Unit, will be following me, and I'm quite confident he'll have more answers than I.
All right, thank you, Senator Riepe. Are there any questions from the committee? Seeing none, thank you. We'll see you close.
I'll be staying.
All right, good. All right, we'll take our first testifier in support of LB 664. Welcome.
Thank you. Good morning, Mr. Chairman, members of the committee. I am Mark Collins, MarkCollins. I'm an Assistant Attorney General, and I'm the Director of the Medicaid Fraud and Patient Abuse Unit in the Nebraska Attorney General's Office. The Medicaid Fraud Unit is a federally mandated law enforcement entity whose two primary responsibilities are the investigation and the prosecution of cases of provider fraud perpetrated by providers of Medicaid services, and the investigation and prosecution of resident abuse, neglect, and exploitation of that occurs in facilities that receive Medicaid funding. Our unit was created back in 2004, and it's opened nearly 2,450 files for investigation. We've obtained 136 criminal convictions, covered over $96 million in settlements and judgments in civil cases, and obtained another $17.3 million in court-ordered criminal restitution in our cases. I speak in support of LB 664, which makes two modifications to our state statutes regarding our ability to investigate and prosecute abuse, neglect, or exploitation that can occur with Nebraska's most vulnerable citizens. First, the bill allows the Attorney General to investigate and prosecute abuse, neglect, or exploitation of of Medicaid recipients who do not reside in an institutional setting. This new authority was passed by Congress in the COVID-19 relief bill that was signed by the President back in January of 2021. Before this legislation passed federally, Medicaid fraud units were restricted to investigating cases only when they occurred in facilities that received Medicaid funding, such as a nursing home. But many recipients of Medicaid receive their health care services in a manner that is designed to allow them to remain at home rather than an institutional setting. And these citizens can be vulnerable to criminal acts of abuse and neglect and exploitation in their homes. So Medicaid fraud unit staff have the knowledge, the training, the experience to pursue these matters, and now are federally permitted to do so. And Section 1 of LB 664 authorizes the Nebraska Medicaid Fraud Unit to conduct those investigations and prosecutions. And Section 2 of the bill amends Nebraska Statute 68945. And as I mentioned earlier, Medicaid fraud control units were authorized by Congress back in the mid-1970s. And one of the missions was to investigate and prosecute and abuse, neglect, exploitation of residents in Medicaid-funded facilities. But that congressional mandate extended to all residents, regardless of whether they were on Medicaid. However, contrary to that federal authority, the Nebraska statute that we operate under prohibits us from reviewing or obtaining information of a non-Medicaid resident, such as a private pay resident, of a healthcare facility without that person's consent or a court order. And as we reviewed the legislative history concerning this anomaly, we don't see a reason for that prohibition, and no other state in the country has that prohibition in their law. That prohibition, it hampers our ability to protect non-Medicaid residents for several reasons. A victim may not be able to consent to the release of records due to their infirmity. A victim may have a power of attorney of someone acting on their behalf, but that person may be a suspect in that crime, and requesting consent from them would tip them off about the investigation. Or obtaining a court order to obtain records can waste valuable time in an investigation, especially if there's been a sexual assault or a physical injury to a resident. So LB 664 fixes that anomaly. It allows allows our units to access the records of any resident in Medicaid-funded facilities when we investigate and prosecute a crime of abuse or neglect or exploitation involving that resident, regardless of whether they're on Medicaid. The federal regulations on this matter are clear. 42 CFR 1007-11B states in part that a state Medicaid fraud control unit shall review complaints alleging abuse and neglect of patients or residents in healthcare facilities that receive payments under Medicaid, and may review complaints of the misappropriation of funds or property of patients or residents of such facilities. The regulation makes no distinction between a Medicaid and a non-Medicaid resident. So LB 664 makes Nebraska's law consistent with Congress's intent. It aligns our law with the provisions found in 49 other states, and it strengthens our ability to protect our most vulnerable citizens. For these reasons, we would respectfully request on behalf of the Attorney General that the bill be advanced to general file. I would note that I have provided the committee with my written testimony, and appended to that is the federal authority that I've mentioned, so that you can see what the federal rule says and what the language in the COVID-19 bill says as well. So with that, I would be more than happy to answer any questions the committee members may have.
Thank you. Are there any questions from the committee? Yes, Senator Ballard.
Yes, thank you, Mr. Chairman. Thank you, Mr. Collins, for being here. I'm asking you kind of a broad question. Can you just paint a picture, give us more understanding of Medicaid fraud? Is it a problem in Nebraska? I know you mentioned some dollar amounts from settlements, but just kind of give me an understanding of the issue this is in Nebraska, and just kind of contrast that with around the country as well.
Well, we do two things. We do investigations of cases of fraud against the Medicaid program that are perpetrated by Medicaid providers who overbill the system and bill for services they don't render, double bill, do things of that nature. And when the unit was founded back in 2004, there were 48 other states who had MFCUs and Nebraska didn't. And so it's only been since that time, in the 17 or 18 years that the unit's been up and running, and I've been with them for 17, that we've recovered, these $100 million, and also gotten over 100 criminal convictions for Medicaid fraud. The other thing we do is investigate cases of abuse, neglect, and exploitation of residents that reside in Medicaid facilities, and hopefully now Medicaid recipients who receive services in their homes. And there have been a lot of cases, especially of financial exploitation, that occur in the nursing home setting, where a person who has power of attorney, a child, a niece, a nephew, has the ability to control a resident's finances, and they're spending that money, they're stealing that money, spending it on themselves, for example, rather than using it to pay for services that would otherwise be available to that resident. And there's a lot of those cases of financial exploitation in Nebraska and elsewhere in the country. It's not a phenomenon that is limited to Nebraska by a long shot. We do see cases not only of financial exploitation, but also of physical abuse. We have also seen cases of sexual abuse. And it's important with the work that we do and the training that we have that we go out into the counties to do these kind of cases, because we have some expertise in the matter. And so it's a valuable service, especially to the rural parts of Nebraska. And it happens out there. It's not just an Omaha problem. It's not just a Lincoln problem.
Okay. Yeah. In your 17 years, have you seen the problem become worse, become kind of stagnant? What have you I'm just looking for trends. Just give me some insight.
On the abuse, or on the fraud side, where fraud is committed by Medicaid providers, and we only look at providers, Medicaid recipient fraud, Medicaid cheats, that where somebody is receiving benefits and they aren't entitled to them, that's investigated by somebody else in the Special Investigation Unit in DHHS. Congress mandates us to do provider fraud. Provider fraud is a constant battle. The means by which fraud is committed change, because people who are engaged in fraudulent activity are always probing the system and looking for weaknesses in the system where they can take advantage of weaknesses, especially in the manner in which Medicaid claims get paid, okay, because it's a largely electronic process. So the problem is always going to be there. It hasn't, what has changed are the modes, the methods, and the means that the fraud is committed. And as far as patient abuse and neglect, we see far too many cases of financial exploitation of residents that reside in Medicaid facilities. It's just amazing. And it can relate back to that, some of the money that a resident might have to pay for those daily needs that were expressed or talked about in the prior bill. And that money's not available to them because somebody is taken.
Thank you for being here. Thank you for your work.
Thank you.
Any other questions from the committee? This bill sounds really familiar.
It should. Yep.
Yeah.
Yeah.
I think somebody introduced it last year, 2 years ago.
Yes, they did. And we appreciate you carrying that for us 2 years ago. And
Yeah.
we're looking forward to pushing it over the goal line.
Okay, well, good. All right, well, seeing no other questions, thank you very much.
Thank you.
And we will take our next testifier in support of LB 664. All right, anyone else wishing to testify in support? Seeing none, is there anybody wish to testify in opposition to LB 664? Seeing none, is there anybody who wishes to testify in a neutral capacity? All right, I don't see any. Just Senator Riepe, if you want to come to close, he waves closing. All right, even better. All right, okay, all right. Well, with that, we did have, I believe, one letter in support from Gina Ragland from the AARP of Nebraska. And with that, that'll close our hearing on LB 664, and we will open up for the next bill, which is LB 13, and welcome Senator Blood to open. Good morning.
Good morning. And hello to my friends yet again at the Health and Human Services Committee. My name is Senator Carol Blood, spelled C-A-R-O-L, B as in boy, L-O-O-D as in dog. And I represent District 3, which is the western half of Bellevue and southeastern Papillion, Nebraska. Thank you for the opportunity to bring forward LB 13, which seeks to expand Medicaid coverage of breast milk in the state of Nebraska. Our intent with LB 13 is to address the ongoing issues of prescribed breast milk for at-risk infants covered by Medicaid. Medicaid taking on this cost to prescribe human breast milk for its clients is in the best long-term interest of the hospitals and their patients. It can be costly for hospitals, and there's no law in place which would protect patients from being charged for breast milk costs or processing fees. With this in mind, we can ensure that both hospitals and patients are protected. Even if a hospital prescribes donor human milk, it is an expense that many cannot afford. The average cost is $3 to $5 per ounce, and babies can consume between 32 and 48 ounces of milk per day. In states where neither Medicaid nor commercial insurance covers donor milk, families sometimes buy unregulated breast milk online or receive donated milk from friends or family because it can be less expensive. In both cases, there is a risk of transmitting diseases or exposing infants to prescription illegal drugs. The FDA, actually warns against buying breast milk from unregulated banks or online marketplaces. Barriers to donor milk disproportionately affects mothers insured by Medicaid, as well as Black infants and American Indian or Alaska Native infants due to their higher preterm birth rates. Even though these populations are the most likely to need donor milk, March of Dimes studies show that they are less likely to receive it at discharge from NICUs. The combination of higher rates of preterm births in Black and American Indian, Alaska Native communities combined with lower rates of receiving donor milk put these infants at increased risk for illness and death. This is a bill that is designed for very specific infants. The infant's birth rate is below 1,500 grams. The infant has a congenital or acquired condition that places the infant at higher risk for development. The infant has infant hypoglycemia. The infant has congenital heart disease. The infant has had or will have an organ transplant. The infant has sepsis, or the infant has any other serious congenital or acquired condition for which the use of donated human breast milk is medically necessary and supports the treatment and recovery of the infant. These morbidities require additional expensive treatments and longer stays in the neonatal intensive care unit. The morbidities also increase the risk of long-term chronic illness, rehospitalization, and neurodevelopmental and neurocognitive delay. Human milk has been shown to reduce both the incidence and severity of some of these morbidities and therefore has an indirect impact on the cost of the NICU hospitalization for the better. Simply put, early intervention with human breast milk can mean reduced contact with the health care in the child's future. This also means that Medicaid potentially will have to invest less money when it comes to potential future claims for that child. This isn't a bill that will allow Medicaid to cover all costs for those who wish to purchase breast milk for personal use. This is only for at-risk infants under 6 months of age who have been prescribed human breast milk by a medical professional or up to 1 year if deemed medically necessary. As of September, at least 17 states and the District of Columbia had enacted legislation requiring Medicaid coverage for donor milk. Indiana became the most recent state last August. Coverage varies based on the patient's length of time and settings. Coverage is required when donor milk is considered medically necessary, but states' definitions vary. For example, Illinois requires an infant to meet one of 7 medical requirements ranging from low birth weight to hypoglycemia. Louisiana considers donor milk medically necessary when several criteria are met, including infant health, caregiver ability, and source of donated milk. State laws also differ in coverage period. Kansas covers up to 3 months of donor milk, New Jersey up to 6 months, and Louisiana covers up to 12 months. Some states require either inpatient or outpatient use, and others cover both settings. Florida stipulates that donor milk is covered only in the hospital setting. Utah covers only outpatient donor milk, and New Jersey covers both inpatient and outpatient milk. Illinois, Louisiana, and New Jersey recently passed legislation requiring commercial insurance coverage for donor milk. These policies also vary in the patients and settings covered and may limit coverage to milk from accredited milk banks. Breastfeeding also confers global environmental benefits. Human milk is a natural, renewable food that acts as a complete source of baby's nutrition for about the first 6 months of life. There are no packages involved as opposed to infant formulas and other substitutes for human milk that require packaging that ultimately may be deposited in landfills. So for every 1 million formula-fed babies, 150 million containers of formula are consumed, and while some of those containers could be recycled, most end up in landfills. So based on data recently given to our office by a Nebraska neonatologist, approximately 10% of all newborn infants are prescribed at least 1 bottle of donor milk. Nebraska had approximately 24,291 live births, according to the most recent census. 35% of those births were financed by Medicaid here in our state. And so it's clear that we've created a need for a prescribed option for these at-risk children. And so I appreciate all of you today for listening and hopefully helping move Nebraska forward to truly being a pro-life state by protecting our most precious resource, our children. And as our current governor continues to preach, Nebraska's future is our children. So I'm happy to answer any questions from the committee, but I think I have several testifiers here that are more knowledgeable when it comes to the medical aspect of breast milk.
Any questions from the committee? Yes, Senator Riepe.
I have a question.
Mhm.
Thank you for being here. My question is this. I assume the donors are those providing the milk. Are those volunteers or are they reimbursed for?
I think we have a neonatologist here today, maybe not, that could answer that question more accurately.
Okay.
So, but the people that give the breast milk are clearly donors. I mean, it's not their child, but I don't know if there's money that passes hands or what the circumstances are, to be very frank.
Because that took me back to the fiscal note, which is 300 and some thousand in year one. I'm trying to sort through whether that was the product cost or whether that's the administrative overhead and delivery cost, et cetera.
If you look at the numbers, do you have all 3 pages of the fiscal note in front of you?
I think so.
I actually had the right fiscal note today, so. So if you look at category 1, which would be 0 to 6 months, they're estimating maybe 35 infants that are under that weight, the prescribed weight we have in the bill. They said the average length of visit is 46 days, which does not mean that they'll necessarily be getting that prescription for 46 days, but that's what they're saying, is that this many kids are born, their average length of stay in the NICU is 46 days. If there was 24 ounces per day, it'd be $450 per ounce. So that would be the 173,880 right there for category 1. Then they go to category 2 and category 3. But the chances of it going beyond category 1 are pretty slim. So I think this is a fair fiscal note, but if we're worried about the fiscal note, I would just keep it clearly at 6 months. And if it's deemed medically necessary beyond that, we can amend the bill to not even say that. I think that they're saying 6 to 12 months, one unique count of patients, 12 months to 12 years, category 3. I'm not sure where they're getting that in the bill, and I have to go back through the bill with a fine tooth comb because I'm not sure that number is coming from. Because the milk's not meant for anybody over 1 year. So,
Yes.
I have a follow-up question.
so that's wherever they're purchasing milk, be it Denver, be it Iowa,
Okay.
or if they are getting it from donor moms in the hospital.
You know, my other concern gets to be, is this is a benefit that's provided by many or even some commercial insurance? I'm real sensitive to the fact that in some cases, my perception is that the Medicaid program itself is a gold program and is much better than many of my constituents can afford. They're resentful of that. And
Fair enough.
in this committee, we are faced with expanded Medicaid over and over and over and over, to the point where it's all of us should want to be on Medicaid.
I guess I would counter that with children don't ask to be born into poverty. And we have Medicaid for a reason because we don't want these children to fall through the cracks, that
Many
it's not
children don't want to
morally.
be born near poverty either, and some of those are the ones that don't qualify for Medicaid, and they're struggling to come up with insurance if they don't have employer base. So
Well, you're talking to somebody
I'm a
who's,
hard, cold, old administrator. I guess it's not.
you're talking to somebody who's self-employed and pays for her own health insurance and has thousands of dollars in medical bills coming in this month for a family member. But I can tell you that I don't slight other people for having insurance that protects their families, because I wish that I had an employer, which we work for the Nebraska Legislature, who doesn't give us benefits.
Well,
I
they
hear
do
you're
at that
saying.
price.
I hear what you're saying, yeah, for a price that none of us can afford unless we're retired and wealthy. So I can say that I hear what you're saying, but you don't know in advance in most cases that you're going to have a child that is premature. And you hope that you have a full-term pregnancy and you hope that you have a healthy child, but that doesn't always happen. And so we've kept this bill pretty narrow. And I do hear what you're saying, but I don't see people wanting to switch over to Medicaid. But that is indeed also what Medicaid is there for, because is it right to allow a child to have lifetime health issues because we couldn't provide them with breast milk for a month? Is it right to allow that child to possibly potentially die, which is what we're talking about? If you look at those illnesses, many of those illnesses are issues that the breast milk is prescribed. It's not a choice. It's prescribed by a healthcare professional. So where do we draw the line when it comes to prescriptions? Are we saying, okay, well, insulin's gone up 10 times more than it was the previous year. I know you really need insulin, but we want you to cut it down by half because the cost is getting to be too much on Medicaid. I mean, where do we draw the line? We have Medicaid. It's available for our children, and well, it should be. Children don't ask to be born into poverty, and there are definitely a lot of people that are not on Medicaid, more now that we've had Medicaid expansion, can afford it. And yeah, there will always be people living paycheck to paycheck that can't afford to have good health care, and that's unfortunate. But at the same token, I know very few people that would fault a child for that. And that's what we're doing, is we're talking about children right now. So I do hear what you're saying, but I look at the aspect as we can't keep saying we're a pro-life state and that children are our future, but say only if that family can afford health care. Because that's kind of what we say when we say things like this, and that concerns me. But that's my personal opinion. I do respect what you have to say, and I understand where you're coming from, but we have an opportunity to give these kids a better start. I would rather give a child breast milk than medication that may or may not work, when we know breast milk in many cases, especially gastrointestinal things, will be beneficial. They will have fewer ear infections. They will have, you're a chiropractor, you know these things. So we know that ultimately Medicaid will pay less on their healthcare expenses if we get it up front.
We also find that children are used as a shield to justify anything and everything. And there are a lot of children that are born into parents that aren't eligible for Medicaid. I go back to the thing that the Department of, or DHHS themselves openly admit that Nebraska Medicaid is one of the richer programs in the country.
Well, good for us that we love our children that are born in Nebraska and we want to give them a good start.
Tell that to the taxpayers too, okay?
I can
Or-
tell you, having traveled the entire state of Nebraska for 14 months, that when it comes to our kids, that people want our kids to have a good start. You hear it from our own governor's lips.
Okay, I don't want to go any further with it. Thank
Any
you.
other questions? I may have a couple questions. Is formula covered under Medicaid? It is, isn't it?
I believe so,
Okay.
yeah.
Because I would,
I will double check that, but it would have to be.
and I have to mirror a little bit of what Senator Riepe is saying.
If it's a
Okay.
prescribed one,
Okay,
right?
I don't even know if
So-
it's prescribed. I think
So
it's
there
in
are certain
general.
types of formula. I think that that would be covered under, what is the federal program in reference to milk?
WIC.
WIC, yeah.
Yeah.
So I do know that if you have a baby with a gastrointestinal issue, and there are certain types of formulas that are prescribed that are really expensive.
Yeah.
That Medicaid does cover that.
Okay, well, I was just gonna say, I have to mirror what Senator Review is saying to some extent about being careful about where we spend our money. However, I would much rather give my child breast milk than formula any day, in my opinion, just because of formula, the way it's made, in my opinion, is not the most advantageous for a child's health. And so I think breast milk, like what you alluded to, can maybe even help cut down on some other ailments that the child might have later on. And so that was just my little quick.
Yeah,
And so,
well, that's right, Senator.
And so the question is, so $4.50 an ounce they had in the fiscal note, is that what Medicaid, like, is that what we cover? Like, 'cause I know
That's what
there's-
they're proposing that it's going to
There's
cost.
an allowed amount, I just didn't know if
Right.
that was the allowable amount, okay. Or if that's just on general, how much it costs, I was trying to figure it out. So, okay, that's all, just had a question about. Any other questions from the committee? All right, seeing none, we'll
Okay.
see you at the close.
Thank you.
All right, we'll take our first testifier in support of LB 13. Welcome.
Hello. Morning. My name is Julie Wagner, JULIEWAGNER. I'm a clinical dietitian in a neonatal intensive care unit in Omaha, and I have over 10 years of experience working with donor human milk as a component of medical nutrition therapy for hospitalized premature infants. With a few revisions, I would support LB 13. Donor milk is an important short-term therapy for hospitalized, premature, and high-risk infants when mother's own milk is unavailable. It is important that NICUs have access to an adequate supply of donor milk for these fragile infants when we do not have enough of their mother's own milk. For instance, studies show that feeding donor milk confers a protective effect against necrotizing enterocolitis, a devastating disease affecting the intestines, in very low birth weight infants when compared with feeding preterm infant formula in the early days and weeks of life. The American Academy of Pediatrics recommends that donor milk be used in high-risk infants when mother's own milk is unavailable or insufficient, and that donor milk use be based on medical necessity, not financial status. The nutritional quality of donor milk, however, is inferior to mother's own milk, primarily due to the extensive processing necessary to ensure its safety. In the hospital, we fortify and supplement donor milk with additional nutrients for our preterm infants, and we closely monitor growth. We transition babies off donor milk and onto an appropriate infant formula well before hospital discharge and well before 6 months of age. Long-term use of banked or otherwise processed donor milk, particularly without close medical management, could put infants at risk of hyponatremia, vitamin deficiencies, and growth failure. I suggest that the language of LB 13 be revised to exclude donor milk coverage for infants over 6 months of age. A gestational age or weight-based coverage limit could also be considered to prevent excessive and unnecessary donor milk use. The majority of level 2, 3, and 4 NICUs in Nebraska are already using donor milk for their premature and high-risk infants in some capacity, with the hospitals assuming the cost. Requiring Medicaid coverage of donor milk for these hospitalized infants would be an important step toward equal access to donor milk for hospitalized infants across the entire state. To my knowledge, 7 NICUs in Nebraska are currently obtaining pasteurized, frozen, banked donor milk from various regional milk banks accredited by the Human Milk Banking Association of North America, known as HMBANA. 2 Nebraska NICUs, including 1 large level 3 NICU, use donor milk from a company specializing in a different human milk processing method that results in commercially sterile, shelf-stable donor milk. This is an important distinction. Shelf-stable donor milk may be chosen by a hospital for a variety of reasons, including reduced labor hours required for preparation, less waste due to longer time to expiration, and improved macronutrient profile due to specialized filtration and processing. The language of LB 13 should therefore be amended to include FDA-regulated shelf-stable donor milk in addition to HMBANA-banked donor milk. I am grateful to Senator Blood for proposing Medicaid coverage of donor milk for Nebraska's premature and high-risk infants to help ensure more equal access across the state to this necessary therapy. I support LB 13 with the aforementioned revisions to include all regulated donor milk products currently in use in Nebraska hospitals and to limit coverage to prevent excessive use. Thank you.
Thank you for your testimony. Are there any questions? Senator Riepe.
I have a question.
Mhm.
And I totally agree with the advantages of breast milk over formula. I totally support that. My question would be this, based on your comment here, says that donor milk use be based on medical necessity and not financial status. If you had a family that was on commercial insurance and they have a $5,000 deductible and they're stressed because of all the other bills that they have, do you think the administration of your, and yeah, if it's an NICU, it's obviously one of the hospitals, and I can probably guess, I could give you probably 2 or 3 hospitals and be spot on. Would that administration then make some concession to that family, in your opinion, or are they going to play the hardball and say, tough, too bad you pay it?
Currently, all of the hospitals that are using donor milk in Nebraska are absorbing the cost and not billing the patient, regardless
I
of,
know that to be a fact.
yes. I'm 90% sure. I've spoken with all of the NICU, the NICUs. Yes, I've spoken with all of the NICUs in the last couple of weeks
Okay.
just to verify.
Well, I appreciate the fact that you've explored that, because that can be a barrier
It can be, yes.
to the kids that quote unquote are medical necessity regardless of their insurance.
Right, so the hospitals see the huge benefit of providing donor milk to a very specific population and the cost savings in preventing all of the various conditions that providing donor milk in a specific context can provide. So right now, anyway, all of the NICUs that I'm aware of, the hospital in Nebraska, the hospitals are absorbing the cost of the donor milk.
Okay, thank you. Thanks for being here. Thanks for coming in.
Welcome.
Any other questions? I'd like to ask a couple of questions, very similar to what I asked last time. Were you testifying?
I did not. I was here to observe.
Okay. Since we test the mother beforehand typically, and then we test the milk after, why do we pasteurize it?
It has to be pasteurized to ensure safety for hospitalized infants. You have to make sure that there's no bacterial growth, no other pathogens, the babies that we're giving this to are so immune compromised. It absolutely has to be pasteurized or sterilized.
Okay, so I thought we tested for viruses and bacteria.
We
as well.
do, but to ensure absolute safety, I mean, I don't think there's any way around it. The way that human milk regulation is set up in the country, it's just too risky to not be absolutely sure that it's been pasteurized or sterilized to be completely safe for those super high risk infants.
All right, good. Thank you. All right, seeing no other questions, thank you for your testimony. We'll take the next testifier in support. morning.
Good morning, Chairman Hansen and members of the Health and Human Services Committee. I am Dr. Ann Anderson Berry, for the record, ANNANDERSONBERRY. I'm a UNMC faculty member and the medical director for the Nebraska Perinatal Quality Improvement Collaborative, or NPIC. However, today I'm not speaking as a representative of the university. I'm here today to testify on behalf of NPIC and in my role as a private citizen with professional expertise on the value of breast milk for infants. I understand that there are ongoing conversations on how to enhance donor milk availability to the most vulnerable infants in Nebraska. As medical director of NPIC, I coordinate collaboration with all of Nebraska's delivery hospitals, support perinatal clinicians, and serve Nebraska communities. With other public health leaders and key stakeholders, we are committed to improving healthcare outcomes for all Nebraska mothers and babies. Implementation of quality improvement initiatives to address perinatal health issues and reduce maternal and infant mortality and morbidity is a key part of this work. In fact, one of our first collaborative initiatives was to increase exclusive breastfeeding in the first days of life across our Nebraska birthing hospitals, and we have made great improvements in this for Nebraska. Breast milk is the best source of nutrition for newborns, especially for those who are ill or premature. It provides all the necessary nutrients for growth and development and contains antibodies and other immune boosting factors that can protect against infection. Neonatologists use donor milk to prevent necrotizing enterocolitis and sepsis. These are the primary indications for donor milk. According to a study published in the Journal of Pediatrics, these premature infants who were fed breast milk also had a lower risk of death and chronic lung disease compared to those that were fed formula. Donor milk is a product that is collected from mothers who have surplus supply after providing for their own infant's nutrition. It is important to understand that donor milk is a processed product and that processing degrades the nutrients present in the breast milk significantly. Plastic containers bind nutrients, antibodies, and proteins, are denatured. Fat-soluble vitamins, including A, E, and the carotenoids, are present at levels of 18 to 53% of those in mother's own milk or formula. Processed human milk ends up with significant deficits as compared to mother's own milk. Donor milk is frequently used as a bridge to mother's own milk in the hospital intensive care setting, but is not an ideal form of sole nutrition for a neonate. It should be prescribed in specific medical conditions and not considered complete nutrition for general populations. I am in favor of financial coverage for donor milk for hospitalized infants who may medically benefit from it if mother's own milk is not sufficiently available. Currently, hospitals are assuming coverage for the cost of providing select high-risk patients with donor human milk when indicated. However, I strongly suggest amendments to LB 13 as written to revise covered patients for donor human milk use. As LB 13 is currently written, I anticipate use of donor milk would expand coverage for a greater proportion of infants who are not commonly receiving donor human milk, and infants where the medical benefits of receiving donor human milk will likely not exceed the cost of financial coverage. I suggest amending the bill to include coverage for infants less than 6 months of age, as there is no medical evidence that this population would benefit, or greater than 6 months of age, as there is no medical evidence that this population would benefit from donor milk, and there is significant risk of malnutrition. I would also recommend input from a team of medical experts from across Nebraska who can work together to provide duration limitations for coverage of specific medical conditions. An example, most infants born less than 1,500 grams only receive maximal medical benefits for prevention of necrotizing enterocolitis by receiving donor human milk until they reach a certain gestational age or weight. Allowing coverage of commercially heat-processed donor human milk purchased outside an established human milk bank would also allow for best distribution of this resource in rural Nebraska. Commercially sterilized shelf-stable donor human milk is available and makes usage more feasible for medical units with limited freezer availability. Likewise, the expiration duration after opening containers of commercially sterilized shelf-stable donor milk is longer than that of pasteurized thawed donor human milk, therefore limiting waste. To best benefit Nebraska moms and babies, we need to ensure that we have appropriate lactation support, high-quality breast pumps for women with state insurance, time to pump at work, and safe places in every workplace to express breast milk. Thank you to Senator Blood for your steadfast advocacy for perinatal health. Support for breastfeeding in Nebraska is critically important as mothers strive to provide breast milk for their infants. LB 13 provides an opportunity to discuss how to enhance the availability of donor milk in rural areas. Healthcare professionals like myself and the NPIC would be pleased to work with the HHS to see how to increase the access of donor milk and improve breastfeeding rates and improve care in Nebraska. Thank you.
Thank you. You should have this down pat by now. I think it's like 10th time I've seen you.
Are you sick of me yet?
No, you're getting right on almost in
There
5
you
minutes too,
go.
right away. It's
Yeah.
good. Any questions from the committee? No, seeing none. Thank you very much. Appreciate it.
Thank you.
Is there anybody else who wishes to testify in support of LB 13? Seeing none, is there anybody who wishes to testify in opposition to LB 13? Is there anybody who wishes to testify in neutral capacity? Seeing none, we'll welcome Senator Blood back up to close. And while she's doing that, I will mention that we did have 15 letters in support of LB 13 and 1 in a neutral capacity.
Fair enough.
Welcome back.
So you may be surprised to know that I actually agree with them that it should be at 6 months. And actually, when we sent it up for drafting, it was at 6 months. So we were surprised when the 1 year came down. And because we were all drinking from fire hoses this year with all-day hearings, and there was quite a line to get things amended, we decided to just run with what we had. So we would be happy to present with an amendment to keep it only at 6 months, because that was our original intent. We feel the descriptions are good in reference to based on all of our research in other states, and based on what we see in the NICUs, we felt that the definition as to who should be allowed the prescriptions of human breast milk are effective. We would strongly encourage DHHS to meet with our subject matter specialists to better define what these children would look like, and maybe change the verbiage a little bit. But we wouldn't need that to move the bill forward once we amend it to 6 months. We can leave that up to DHHS. And DHHS does have a breast milk specialist, by the way, already, just so you know. Because as you remember when we talked about the milk bank, that we have known since I think it was before 2014, that it used to be our report card when it came to breastfeeding was dismal in Nebraska, which is surprising to me. And so efforts were made by the legislature and by experts in Nebraska, such as many who have testified over the last few bills, to move things forward. And now we're in a much better place. But we can't let that change. And I'm glad that Senator Riepe got an answer to his question in reference to the hospitals absorbing this cost. As we know, hospitals, many are struggling right now because they are experiencing a shortage in their workforce. And they're paying more for workforce because they're bringing in nurses from other states to fill in, and physicians from other states. We know that right now the state's not being very friendly when it comes to financial support, at least with the initial budget that's been presented. Excuse me, I have to cough, I apologize. Not COVID. I just know that we can do better. This is a great bill. This is consistent, and the fiscal note drops substantially when you go back to the 6 months. I believe it goes to like 170,000 is what it says in, and that is doable. You don't see DHHS here coming in against it. We have already discussed it, and they're very excited to continue the movement to make sure that every child has a good start in life.
All right, thank you. Are there any questions from the committee? All right, seeing none.
All right, thank you for your time. This is my last breast milk bill I have for this year.
Okay,
All
all
right.
right, good. All right, well, that will close our hearing for LB 13, and that will close our hearings for this morning.